So dysmenorrhea, difficult monthly menses, that's exactly what it says out of the book. Some of the risk factors that can contribute to this, cigarette smoking, or it could be that maybe they got some other issues going on, like, for example, endometriosis, which we'll talk about a little bit further as well. It talks about with this that you can have primary or kind of like, I don't know if they really call it secondary, but it can be, it mentions there the primary, it talks about, how even diet stuff can contribute to it. High levels of omega-6 fatty acids in the Western diet, those could contribute to having more symptoms. In primary, that means that is the primary cause. In the dysmenorrhea that could be contributed to by endometriosis, that would kind of be more of a secondary type thing. But in the primary, it could be phospholipids of cell membranes after ovulation, so buildup of those, or also the diet changes that can contribute to that. It talks about some of the prostaglandins and the leukotrienes in the uterus and all of those things. So it's just complicated stuff, but just to understand that there is pathophysiology to it all. So what are the clinical manifestations? Things like I said that you would be familiar with: cramping, headaches, nausea, vomiting. Generally, the symptoms are going to occur for 24 to 48 hours, and then they would kind of come cyclically. They would be associated with the time of the month where the menses is actually occurring. Some of the medications, the mainstay of treatment is going to be the NSAIDs. So think about, the Motrin, ibuprofen, and the purpose of them is to reduce the number and the production of the prostaglandins, because we know that the prostaglandins are the contributors to pain. This does cause a decrease in the uterine contractions, and that can help with lessening the symptoms. If they would start the NSAIDs about 1 to 2 days prior to their menstrual cycle, and then continue them until the symptoms resolve. Another medication that you see mentioned in your book, they may also use combination oral contraceptive pills to help with some of the symptoms. So the combination would be estrogen and progesterone. So NSAIDs or the combination oral contraceptive pills could treat the primary dysmenorrhea. Some other things too, if the ovulation is prohibited, obviously, we know that could help with the symptoms. And then you're gonna see several other medications, different types of contraceptive devices that may be used, like the NuvaRing, Depo-Provera injections, IUDs, and all of those are going to interfere more with the cycle every month. So therefore, they could help with decreasing some of the symptoms associated with this. So like we mentioned already, there is, it's usually gonna be cyclic, so it's gonna be pretty predictable as to when the symptoms are going to occur. You see mentioned there in your book, as well as on the slide, some of the non-pharmacological therapies. So the TENS unit may be helping with decreasing some of the inflammation that could be going on. Maybe a heat pack, physical therapy, maybe physical activity. I don't really know how physical therapy would help with that. Dietary supplements, it mentions the omega-3 fatty acids have been shown to improve symptoms. So all of these non-pharmacological therapies, they have been shown to provide relief, and they can help with the release of some of the natural natural endorphins that can help with decreasing the pain, maybe increasing the pelvic blood supply belt, and then, that can help with the production of less potent prostaglandins and leukotrienes that are really, contributing to the pain that the dysmenorrhea is as a result of the menstrual cycle with all the pain and the, cramping and all of those things, and all of those symptoms. So when the hormonal methods are used, I mentioned that you would do the oral contraceptives, a combination of the estrogen and the progesterone. And what they really work to do is limit the endometrial growth, and then therefore there's less number of the prostaglandins and leukotrienes that actually are going to be causing pain and causing problems. So the first treatment was what? Which one we mentioned? NSAIDs, and then you kind of progress from there. And so if there are prescribed medications, they're typically going to come in the form of the oral contraceptives. So as far as your nursing management, giving the NSAIDs as ordered, we know that the clinical manifestations are going to kind of be pretty predictable on the cycle, monitoring their pain. What's the best way to monitor someone's pain? Exhale by asking them what they tell you is the best way to monitor that. And then just monitor the boy with different signs and symptoms. Page 1514 does talk specifically about some interventions that could promote comfort. That's really just, yeah, it just that we talked about it, that medical management, there's not like a table or anything else, that's what I was double checking, there's really not. So any questions about dysmenorrhea? So endometriosis is the next one that we're gonna discuss. Probably should be going a little differently.
So 1515.
Say the page again?
1515.
I was gonna say, it has to be right here. There we go. Okay. So I had already moved past it on accident. Okay. 1515, thank you, Heather. Endometriosis, so this is a little more than just dysmenorrhea, symptoms with the cycle each month. This is a lot more involved. So the problem with endometriosis, let me see. So this, I want to go to this picture first, just because you see this picture in your book, and that is on page 1515, but as a result of some abnormal hormonal activity, that's kind of how it's described in your book, there is some interactions with the enzyme aromatase and the enzyme and that's the enzyme in the synthesis of estrogen. So you think about, using it or synthesizing it or putting it into action or whatever. So interactions with those two has caused an issue with, there is this endometrial tissue that should only be in the uterus. Now in this picture you can kind of see it displayed where it's attached itself to all different reproductive structures all throughout the peritoneal cavity. So that's what you're dealing with when they're able to visualize the endometriosis with clients that are diagnosed with this. So I'm gonna go back now to the beginning, but I just really like that picture. And you see where it does talk about how there is an interaction there between the aromatase and the estrogen. And we've got an issue with all this endometrial tissue that should be in the endometrium or inside the uterus. Now it's being implanted, all of them, in the pelvis. The ovaries are usually the most likely sites for implants. So that's why oftentimes when you hear of clients with severe endometriosis, you're going to see them also have issues with fertility. And that kind of explains that, because the ovaries are often the most likely site for the implants of this. And it does go into other locations that it may implant. So, the clinical manifestations, we just talked about the dysmenorrhea, so that, the cramping, the nausea, the vomiting, the headaches. They also may have excessive bleeding during menses. They may also have pain during intercourse, which could be contributed to some of this tissue being all in the wrong locations. And then, like I said, the infertility is a big deal because of that endometrial tissue attaching itself to the ovaries. Kind of seems to be the spot where it likes to go. So, the signs and symptoms of this one specifically is the dysmenorrhea, but the problem with this one, what was the first treatment we were gonna use for it? NSAIDs. When it's dysmenorrhea that's associated with endometriosis, it doesn't respond to NSAIDs. So, this is dysmenorrhea that does not respond to NSAIDs. So it's different from just traditional dysmenorrhea.
So this is a type of dysmenorrhea?
They have that symptom, so to speak. So it's the symptoms of it, but when usually they show the symptoms of dysmenorrhea, we can do NSAIDs and they should be able to find relief. But when endometriosis is causing it, the NSAIDs will provide relief. So for endometriosis, the first line of treatment is going to be oral contraceptives. Because we're trying to decrease the estrogen. Because remember we talked about from the beginning that we have this aromatase enzyme, and that's increasing, and that's leading to a significant quantity of estrogen being produced. So we're going to be talking about a couple of different medications with the goal to try and decrease the estrogen. So oral contraceptives are the first line, but then if these fail, some other approaches to be used could be the gonadotropin releasing hormone. And an example of one of those is Leuprolide or Lupron. Any of you familiar with anyone having to get those? This is an injection they have to get. So page 347 in the ATI Farm Book is where you're going to find the information about it. Lupron, Lupron. Leuprolide is another name for it. But page 347, and where you're going to find it, page 347 is actually talking about some hormonal agents for prostate cancer. So this is going to come up again when we talk about prostate cancer. But it can also be used in the instance where there's endometriosis, because it's going to it decreases estrogen, and then also decreases testosterone, so that's where it can also help with prostate cancer. But it puts the client in a hypoestrogen state, and that is going to impair the action of that endometriosis and the proliferation of it, and implanting that tissue in all those locations where it doesn't need to be. So we're going to go into that medication a little bit further, because there's some information that I want you to know about that. So we know that the Lupron or the Leuprolide is going to decrease the estrogen, and that's going to decrease the endometriosis lesions. And so if we can decrease the lesions, then the therapeutic response we want to see it improve their pain and tenderness that they're having. It's going to improve their painful menstrual cycles. The Lupron also can improve the symptoms of painful intercourse. So if they are taking this medication, we wanna be sure that they're taking measures to be sure they don't get pregnant during this time because it's pregnancy category X. Lupron is typically injected once a month. And then there's a lot of side effects, okay? And when you think about, if we're gonna put them in a hypoestrogen state, think about those menopausal symptoms, and that's kind of all the symptoms you're gonna see associated with this. So, what's the first one that comes to your mind? Hot flashes, yes. Headaches. Their menstrual cycles are going to stop. They're going to have decreased libido, depression. They're going to experience dizziness, nausea and vomiting. They may have some pain. Weight gain is an issue. And they can have decrease in their bone density. Because like I mentioned with the breast cancer treatments, if we've got something that's messing with their estrogen level, we know that can contribute to osteoporosis, decreased bone density. So we're gonna be sure to educate them to increase their calcium and vitamin D intake. So we try the oral contraceptives first, kind of as the first line of treatment, but then if those fail, then we take further measures, and then Lupron is another one. Another set of medications, but it's really still under investigation. We don't know that it's been approved as a treatment for endometriosis, but those aromatase inhibitors, like we talked about, those, we talked about the tamoxifen, to decrease the risk of recurrence of breast cancer because of what it does with the estrogens and everything. So those have been under investigation. Don't know if that's approved yet or not, but that is Arimidex. And some of the other names of those aromatase inhibitors that you may hear mentioned besides just the tamoxifen, but Arimidex, Femara, but they're going to stop estrogen production as well. So therefore they could help with the proliferation of this endometrial tissue. But they are considered experimental. The most common, or I would say they say that surgery really is gonna be more of a better outcome than the medications. So they may try some of the medications, and then if those fail, they may move to surgery. Depending upon the severity of it though, they may say that surgery is a better option earlier than some of the medications. But it does talk about the surgery in the book, but laparoscopic surgery, and what they do is just try and remove some of the areas of the visible endometrial tissue. Maybe they can actually cut it out, cauterize some of the tissue, use a laser. All of those ways are mentioned. And then after they have the surgery to kind of get things cleaned up, they may also go with some of these medications that we mentioned to try and help with preventing the recurrence of the endometrial tissue proliferating again. In those extreme cases, it may be necessary for them to have a hysterectomy. And that would be removal of the uterus for sure. They may or may not remove the ovaries, so they may leave the ovaries so that way the mother, the female is not, doesn't have the symptoms of the early menopause that removing the ovaries would cause. But the removal of the uterus and the ovaries is identified as the best option for less recurrence of the disease. So they just kind of have to, the benefit versus the risk is just gonna have to be kind of of weighed out, because it does mention in your book that having the ovaries removed younger than 40 is going to be, it could kind of, be associated with that loss of estrogen at that young of an age. You know, we know that there are risks associated with that.
So do they have like cramp type pains more often than just on the period?
Yes, yes. And then the farther reaching effects as far as fertility and things like that. And it's usually, the excessive bleeding is another clinical manifestation that we mentioned. And it's kind of pain that is a little more out of control than just the dysmenorrhea pain that was mentioned. Yeah. And then also, you know, you have to think about with the surgical treatments, how if this is a younger woman of childbearing years that desires to have children, they need to be, you know, they may need to be more cautious or use more of a conservative type of treatment in those individuals. So, but if there are issues where it's causing a restriction some way in the fallopian tube, or like I said, it's attached to one of the ovaries that is affecting their fertility, then they may be able to do some type of surgery in order to make it possible for them to be able to have a child. So, we mentioned the medical management and the surgery, we talked about those. And so when you think about, I don't know if it goes into it in great detail here, but if you think about a client that does have to undergo hysterectomy, you know, think about you want to think about their limitations and, you know, how much are they lifting and taking those extra precautions, and then the general information for surgery too, you know, make sure they're getting up and walking, and because they are going to be at risk for DVTs, and being sure that they are. You're implementing those standard surgery type procedures with these clients that you would with anybody else to prevent surgical complications. Here's that picture that we talked about. So there's some of the complications because of all the scarring, chronic pain, fertility. So that's very weird. The catamenial pneumothorax, but I guess that is if the tissue attached itself some way, that it could actually lead to a pneumothorax. So that seems very odd. But we're going to kind of be monitoring for being aware that they increase aromatase, increase estrogen, the pain that they're having, excessive bleeding, infertility. So we're going to be monitoring for all of those symptoms and doing what we can to help with symptom management. They could experience chronic pain, like you said, it's not pain, it's just going to come with the cycle. It can be pain that can go on anytime throughout the month. Administer medications, keeping up with a menstrual calendar because it can affect their menstrual cycle. It says that endometriosis can be cyclic, but they also need to chart their symptoms in relation to the menstrual cycle to determine whether there are any types of patterns with this and the cycle. And then being sure that we're trying to adequately control the pain. So any questions about that? So from there, we are going to move on to menopause. So at this point, usually this is going to be more specific to an age that they're going to actually reach this condition. The pathophysiology, the ovaries no longer produce estrogen. They're no longer ovulating. Menses is no longer occurring. They're becoming irregular. And then when there is identified that there's been 12 months of no menses, that's the point that, I think that's when they say that they're actually in menopause. You have to go 12 months with no vaginal bleeding for it to be considered menopause. Yes.
How does that go to play with, like, for the ladies who were on birth control, or they're switching their birth control plans, and their period becomes irregular, and they're like, cause I know a girl who, her period didn't come on for like a year, but she's menopause.
Well, in some of the oral contraceptives that we talked about, like Mirena and the NuvaRing, some of those things, they don't have a menstrual cycle. Yeah, that's just kind of the therapeutic action of them, with decreasing those, with manipulating those hormones, however it releases that medication, they usually don't have one. So that would be, medication related, whereas this would be without medication, and they're just becoming of the age where their cycles becoming a lot more regular, and then when they go 12 months without one, it would be considered menopause. But when you got medications in there, it wouldn't be considered. So we talked about already, one of the most common symptoms is the hot flashes. We've mentioned it multiple times too. Some of those complications can be the bone loss, the osteoporosis, because you don't have, there's no longer, the ovaries are no longer producing estrogen. Now, one situation where age would not be a factor would be those younger women that have the hysterectomy where they remove the ovaries. So if that's the case, then you could have a younger individual that is thrown into early menopause as a result of the surgery that you have. Another thing is the central weight gain, increasing the risk for cardiovascular disease, increase in their cholesterol levels, increased risk for type 2 diabetes. So that's where it really kind of comes to, as far as medical management, it comes to, is the female going to choose to do the hormone replacement therapy? Because the estrogen is the most effective treatment for the symptoms of menopause. That's going to help with decreasing the risk for the bone loss and osteoporosis, as well as decreasing the hot flashes. But we know that it has to be used with caution, because you have to weigh the benefits versus the risk, because especially if we have a client that has a history of breast cancer, they wouldn't be a candidate for that. Or if that is a client that has a family history, a strong family history of having breast cancer, it could be risky for them to, use hormone replacement therapy. So, all of those factors kind of have to be considered, but for knowledge purposes, that is going to be the best treatment for the hormone, but it may not be the best treatment for every patient, depending upon their other history. So they have to be sure, we just want to be sure, and that's kind of what it goes to more in there, is that there is kind of a limit on how long they can stay on the hormone therapy if they do choose that, but then they also just need to be sure that they're educated well about their risk.
So it's kind of like men, like when they get older, they can kind of get on testosterone.
True,
I
yes,
guess,
because
but-
of the levels, and then there's that's gonna carry risk associated with that as well, yeah, that's right. Because those levels decrease with age, just as the females. We talked about some of those complications, the fractures associated with the osteoporosis, that central weight gain, so the heart and the increase in their cardiovascular and increase in cholesterol levels are an issue. And then our management, the symptoms are going to be a lot associated with how low the estrogen levels are. And then our other things that are coming with us is some of the interventions, vital signs, identifying, okay, it has been a full 12 months or it hasn't been quite 12 months since the last menstrual cycle, monitoring their weight, monitoring their laboratory values. They may also need to be educated, with some of the side effects that they're dealing with. You want to be sure that they are maintaining, like, the importance of maintaining the appropriate amounts of calcium and vitamin D, taking those supplements in their diet as a result of the the risk associated with, it's not really there, but the risk associated with the fractures and the osteoporosis. Another thing, what's some other, activities that you can encourage them to do?
Weight-bearing
Weight-bearing
exercise.
activities would be appropriate, yes. So anything that, swimming may not be the best thing. Walking would be a better option because that's more weight-bearing than swimming activities would be. So calcium, vitamin D, weight-bearing exercises, all of those things can help with, maintaining their bone health. In those clients with maybe they already have some osteoporosis or they have the fractures, then hormone therapy may be appropriate for them. We kind of talked a lot about the pros and the cons. So as far as with the vaginal atrophy that they're experiencing and the related symptoms, the dryness and everything, they need to be educated about using some appropriate over-the-counter lubricants. Things like that would be appropriate to be sure that you educate them about. Sleep disturbances, mood changes, joint pain, they can start seeing memory decline, fatigue. So the loss of these hormones can make a lot of changes in the clients. And so just monitor for those things. You will also see, and I don't know if it really talks about it here, of course, turning down the dressing in layers, avoiding caffeine, even eating excessive chocolate which does have caffeine in it. Those things can also contribute to some of the symptoms with the hot flashes. They may have palpitations. So decreasing the caffeine, dressing in layers, keeping the environment cooler, all of those things can help with some of the side effects. And then also the SSRIs, gabapentin, clonidine, those are some other medications that you may see clients use if the hormone therapy is contraindicated. So those can help with relieving some of the symptoms, like the hot flashes and things like that. So,
Wonder if estrogen hormone therapy will stop or decrease the weight gain as they get older. Like,
if
will
they
it
did the
stop
hormone
it?
therapy,
Yeah.
yes,
It
it
would
could.
stop the weight
It
gain.
could help, yeah, because the lack of it contributes to it. Probably messes with the metabolism somehow. I don't know that pathophysiology of it, but and another thing you're talking about the testosterone. So like several of you probably have heard of people like getting the hormone pellets.
Mm-hmm.
I mean, even younger individuals, because of those deficits. And a lot of times they get those pellets and then they're able to lose weight and have more energy and all of those positives from that. So that it could definitely help with the weight gain if they do hormone therapy, since that seems to play into it. We talked about those other medications, maintaining a healthy diet, to try and maintain a healthy weight, exercise regularly, take their calcium and vitamin D supplements. So, and then it's important really for them to kind of begin these behaviors and start these things at a younger age, because then, especially with like the calcium and the vitamin D and the bone loss and the weight bearing exercises, those sorts of things, if you wait until that point to begin those things, the amount of bone loss is probably going to be too great for you to make up at that point. So, even early on, especially like me, out of every osteoporosis risk factor that there is, family history, the color of my hair, the color of my skin, everything. I have every short stature, I have every risk factor. So, I was told that years and years ago the importance of me taking calcium and vitamin D at a younger age. So, those are things that you need to kind of start, especially when you have risk factors. And so if you're working with clients and you're working, especially if you're like in an OBGYN clinic where clients are coming in and you're seeing these things, that should be an important part of your education. So, so that's pretty much all menopause. So any questions about that? layers could help, so that way, you know, if you're somewhere where you're feeling chilly and then you were having a hot flash, then you could take sweaters off or, take off a long, sleeve and have a sleeveless top or short sleeve or something. So dressing in layers would definitely be